I sort of sense attention, but also agreement here that, you know, there's a fine line between a balancing act, you know, what's right, what's appropriate given the many choices, but at the end of the day, how clinicians and patients can kind of get what's needed. So beyond what we've talked about, any ideas or solutions about how we can get the payers, providers, and patients to sort of work this out a little bit more effectively?
I'd like to jump in on that because I took some notes last night. Just like this panel is doing this think tank and exchanging ideas, why can't payers like Aetna, United Healthcare, have think tank summits? Bring the providers and the payers together at least once or twice a year in different regions of the country to discuss the issues on each sides of the fence, to make better payer decisions, better provider clinical decisions, to get the people together. Almost like, you know, not to bring politics into this, but one of the things that people like about President Trump is that he likes to talk to people. Let's get the people in the room. Let's get all the CEOs of the oil companies and all the CEOs of the car companies, and let's talk and have an understanding. I think that would be a really important step forward.
Well, I'll tell you that is actively going on, particularly in places where there's a relationship on a value-based contracting or an accountable care organization where the physician group has taken on some risk, but in turn have taken on some reward if their patients do well. And there are usually quality metrics within that, so that you can't do well cost-wise by doing poorly clinically. And for instance, one common metric is an A1C over 9. No one should have an A1C over 9. And we will have conversations with ACO partners where they want to spend that money. We want them to spend that money. We want to get that A1C for that member down, and we're discussing ways that we can do that and how can we leverage whatever's available to make sure that, is it an issue of inadequate therapy that they're receiving? Is it inadequate education and they need to utilize their benefit to see an educator or a nutritionist? Is it a pharmacy issue? Do we need to mobilize whatever resources are available to make sure that their therapy gets covered? So those conversations are now occurring.
Honestly, saying that the A1C over 9 is the issue is really far away from some of the science, because there is very good evidence that a person who develops diabetes, let's say at age 65, has a life expectancy of well over a decade. And we have good trials that compare A1Cs of less than 7 with A1Cs of greater than 8, and show that retinopathy occurs more commonly, myocardial infarction occurs more commonly. You know, the careful analysis of the cardiovascular outcome trials shows that it's really all about glycemic control. And so what we want and what we think is appropriate is to encourage approaches to therapy that don't cause hypoglycemia, don't cause weight gain, and do lead to excellent glycemic control. And this is, it's constantly a moving target because we have better treatments.
Solution out. You know, I think greater sharing of information and transparency. So there's no reason that every provider shouldn't be able to know when they're talking to a patient about what insulin to go on, which one would be the cheapest for them. That should be clear information that is just available at the point of care. And then the other piece is, if we want to sort out the high costs of insulin, really understanding what goes into that and some greater transparency on how this process works, because right now it's pretty murky, and I think, you know,
pricing.
Yeah.
How prices are determined.